Hello everyone, and thank you for joining us, and welcome to the Cancer Research Institute's webinar series, Breakthroughs in Cancer Immunotherapy. Today's date is Thursday, February 20th, 2014, and today we're going to learn from a leading expert about significant breakthroughs in the treatment of leukemia and lymphoma, as well as other cancer types. My name is Brian Brewer, and I'm Director of Marketing and Communications for the Cancer Research Institute. The Cancer Research Institute is a nonprofit organization dedicated to advancing new cancer treatments that harness the immune system's power to conquer cancer. We fund scientists around the world whose work has led to significant breakthroughs in treating cancer with immunotherapy, including long-term remissions in patients with cancers that are difficult to treat. Over the next 45 minutes, you'll have an opportunity to hear firsthand from an immunotherapy expert how cancer treatment today is undergoing a revolution thanks to these breakthroughs. After a 15 to 20-minute presentation from our speaker, we will open the discussion to questions submitted by you. You can pose your questions at any time throughout the presentation by typing in the Q&A box on your screen. We'll do our best to get to everyone's questions. Today's webinar is being recorded and will be made available for viewing on the Cancer Research Institute's website and on our YouTube channel. Now it's my pleasure to welcome today's expert speaker. Dr. Holbrook Kohrt is an assistant professor at Stanford Cancer Institute in Stanford, California. His research focuses on finding and developing new cancer treatment strategies that enhance the immune response against cancer. He is best known for his work in developing antibodies that modulate the immune response, currently one of the most effective immunotherapeutic approaches, which we'll learn more about today. A promising antibody he developed is now in early phase clinical trials in the US and 3 other countries. Dr. Kohrt also has developed new vaccine strategies designed to train the immune system to attack cancer. We'll hear more from Dr. Kohrt about these treatments that hold great promise for patients dealing with leukemia and lymphoma, as well as other cancer types. Dr. Kohrt attended Stanford University Medical School as the Baxter Foundation Scholar, a Howard Hughes Scholar, and an American Society of Hematology Research Fellow. In that time, he developed a new technique for predicting clinical outcomes in early-stage breast cancer patients. Dr. Kohrt is pioneering powerful new approaches to treat cancer with the immune system, and it's an honor and privilege that he could join us here today. As a reminder, we encourage you to type your questions into the Q&A box. And with that, I'd like to turn the presentation over to Dr. Kohrt. Dr. Kohrt, welcome.
Thank you, Brian. It's a pleasure to have the opportunity to discuss my research today. But more so, I would like to provide an overview of the landscape of where we are in terms of immunotherapy for the management of leukemia and lymphoma. The past 5 years, we have seen incredible advances in this field, and we'll have the opportunity to try to review and put them in perspective today, and to share with you some of my excitement for where we will be in the future. This challenge is really the opportunity to better understand the immune response against a tumor and how we can harness that to allow patients to hopefully not need cytotoxic chemotherapy in the future and rather to use their own immune system to fight their tumor. I'll briefly review some of the history of immunotherapy in this area, some of the barriers to our immunotherapies, and the major advances. Again, hopefully I will inspire you during this period of time, and hopefully I will be able to explain why we believe immunotherapy is the next weapon of mass destruction against cancer. I will hopefully also try to explain a little bit of the black box of immunotherapy, because I think this is a very challenging area for us all to understand. But at a very basic level, I think it's a unique opportunity for us to provide patients therapies which preserve their quality of life and are very effective. If we look at the history of the management of cancer, really surgical history began in 1890 with the first radical mastectomy. Radiation, another standard of care, also the late 1890s. Chemotherapy really was not developed until the late 1930s and 1940s. One of the first agents was actually used for the management of lymphoma, and that was nitrogen mustards. So where does immunotherapy fit on this spectrum? Well, immunotherapy fits on this spectrum actually even earlier. The first immunotherapy maneuver was actually done back in 1860. What was observed back in 1860 by this gentleman, William Cooley, was a patient who had an infection with erysipelas or strep pyogenes. And what he observed was, at the same time as having this infection, the patient's tumor appeared to melt away. Based on that observation, when he saw another patient with a sarcoma of the neck, he decided that he would actually inject the bacteria into it. After injecting the bacteria into the tumor, it actually disappeared. This was the first example that we could use a patient's immune response to fight a tumor. We are actually doing very similar things even now today, 130 years later. At Stanford, we have a clinical trial where we're injecting CpG. It looks very similar to bacteria to our immune system, and we're also providing a low dose of radiation. The goal is that by this simple maneuver, we're able to induce an immune response that can treat distant sites of these patients' lymphoma. This is one patient that was treated. This patient was treated to a spot in the back of the neck. What I'm showing you here are lymph nodes that are present in the left and the right armpit area. After the patient was treated, again in the back of the neck, what we observed was that these lymph nodes in the axilla or the armpits actually began to disappear. This is a scan at 12 weeks, and this is another scan at 24 weeks. And what you can see is those lymph nodes are now actually gone. So the same idea that was started by William Cooley 130 years ago, we're still using today, and we're getting systemic responses. These are actually using the patient's T cells to fight their tumor. What else can we do with a patient's T cells? A patient's T cells are a critical part of their immune system that we can adoptively transfer. Adoptive transfer is when we take a patient's T cells out of their body and then we manipulate these T cells in a dish in order to make them specific and functional to go back into the patient, and once they're in the patient, hopefully they will attack that patient's tumor. The history of adoptive T-cell therapy is actually much shorter, really began in the late 80s. And as you can see here, it's been really used to treat mostly lymphoma and hematologic disorders, like post-transplant lymphoproliferative disease and EBV-associated Hodgkin's disease. This process of taking the cells out means that we can manipulate them in a dish to make them very, very specific for a tumor. This technology is known as CAR technology, chimeric antigen receptor T cells, where we put a specific signal that allows these cells to go back and recognize just the patient's tumor. These are some examples of the types of responses we've seen with this technology. We've actually seen patients' liver lesions significantly decrease in size over time. We've seen patients' lesions on the chest disappear. Even lesions in the brain disappear as well. This technology is so significant, it was the focus of a New England Journal paper last year. This technology has also been featured in the New York Times 3 times over the past year as well, for incredible responses that have been seen with patients who have acute lymphoblastic leukemia. This is one of those patients. And what you can see is that this patient's lymph nodes, after they receive these chimeric antigen receptor T cells that are reinfused back into the patient and they home to the tumor, these lymph nodes disappeared. Here's another example of a lymph node that also disappeared as these T cells were transferred back into the patient. This work that's been pioneered by Carl June has been very impressive. This was done at the University of Pennsylvania, and here you can see patients that had a complete response to this type of T-cell therapy. So that's one part of our immune system, and it shows how impressive these responses can be. The other part of our immune system is the humoral immune system, or the body's B cells. These cells are responsible for making antibodies. The history of antibodies itself dates back to about the mid-1970s. At that time, Koellner and Milstein developed a technology to mass produce antibodies at the scale that would be necessary to use as a therapy for patients. The first real advance in the area of antibodies was an anti-idiotype antibody. This is an antibody that goes out and it recognizes the specific signal on a patient's lymphoma. This work was pioneered by my mentor, Ron Levy at Stanford. This is the first patient that was ever treated with an anti-idiotype antibody. He actually had a complete response to his therapy and an 8-year remission, and he recently died just a year ago at the age of 99. Henry Kaplan, who's considered the pioneer of radiation therapy, particularly for Hodgkin's disease and other types of lymphoma, has a great quote. He said, "It is very important that the experiment work the first time. Anti-idiotype worked the first time, giving a patient the complete response as you saw." Ron Levy's next big effort was to develop Rituxan, also known as rituximab. This is an anti-CD20 antibody. CD20 is expressed on the surface of most non-Hodgkin's lymphomas. Rituxan has actually become the standard of care for patients with non-Hodgkin's lymphoma because Rituxan also worked the first time. The first patient treated developed a complete response and is still alive today. Antibodies work by many different mechanisms. What we know is that antibodies can deliver signals into the cell that turn that tumor cell off. They can recruit our body's complement system that also helps to attack the tumor. They can be part of our body's vaccinal response, which means that our body's T cells are responsible for attacking the tumor. And last, they can recruit our body's innate immune system. These are our natural killer cells and other monocytes that are responsible for a process known as ADCC, or antibody-dependent cell-mediated cytotoxicity. In the process of ADCC, Rituxan binds to CD20 on the surface of lymphoma. After it binds to the surface, this activates our body's immune system, and it secretes factors that are then responsible for attacking and killing the tumor. These advances have also occurred in the setting of other hematologic malignancies, such as acute myeloid leukemia, in which we have an antibody known as gemtuzumab, which targets CD33 in the surface of AML. Antibodies have become big business. Rituxan, on average, is approximately $3 billion of sales every year. If we look at gemtuzumab, partially because the number of patients with AML is much less, it's approximately $100 million per year. But regardless, it shows the significant impact and the number of patients that are receiving these therapies. One question is, how can we make our antibodies better? Possibly we can find other targets besides CD20 on the surface of leukemias and lymphomas. This has been a big effort. We've identified numerous different targets that we believe would be potentially promising. Once we identify these targets, we then develop mouse models to try to validate these targets. And then we bring them into clinical trials. And this is how antibodies like gemtuzumab have actually come to the market. In addition to finding antibodies which recognize our body's different cell surface markers, we are also looking to find antibodies that recognize the specific cancer stem cells. What we've been able to identify are a series of different markers which are expressed in our body's stem cells and not expressed on our normal hematopoietic cells. This is important because we can now target the cancer stem cell, which means that we could have therapies which are much more effective than previously. One of such antibodies was developed by Irv Weissman at Stanford. This antibody is known as CD47. CD47 provides essentially a don't eat me signal to our body's immune system. When a tumor expresses this, our body's immune system is unable to go and actually attack and eat that tumor cell. By providing an antibody which blocks that signal, the don't eat me signal is no longer expressed, and our body's immune system can actually go out and attack the tumor. There will be a clinical trial starting later this year of the anti-CD47 antibody for patients with AML. Another antibody is targeting WT1. WT1 is expressed on the surface of AML. WT1 is the #1 rated cancer antigen, and in early mouse models it looks incredibly promising. There are currently multiple antibodies in clinical development, and hopefully these antibodies will make a significant impact on patients' clinical outcomes. What else can we do to make our antibodies work better? We can conjugate our antibodies to different toxins. Gemtuzumab that I mentioned previously is actually an antibody that's conjugated to a toxin. This toxin prevents our body's DNA from normally replicating, and by localizing it or targeting it to the tumor with this CD33 antibody, we're able to specifically give the toxin just to the tumor cells. We can also take our antibodies and conjugate them to different forms of, say, radiation. Radio-labeled antibodies are essentially a normal antibody that's then tagged to a radioisotope. What you can see here is a patient that received Zevalin. This is a form of a radioisotope that's conjugated to CD20, just like Rituxan. And you can see that over time, this radiation actually specifically localizes to the areas that the patient has tumor. We can also improve our antibodies by making them a little bit more fancy, such as increasing their ability to target just CD20 or to target 2 different markers on the surface of cells. These types of antibodies are known as byspecifics. They target not only 1 surface receptor, but 2 surface receptors at the same time. Bispecifics have made a very impressive impact for patients with acute lymphoblastic leukemia. The bispecific that I'm showing you here targets CD3 on one end, and on the other end it targets CD19. By doing that, it brings the tumor cell directly in contact with the body's T cells. Therefore, the T cells are able to attack and kill the tumor cell. And we've seen response rates as high as 80% in patients who have previously not been able to develop a response to standard of care chemotherapy. Bispecifics are also being developed for acute myeloid leukemia, and these bispecifics bring CD33, which we already know is expressed on the tumor cell, next to CD3, which is part of the T cell. So again, just like the CD3, CD19, this brings our body's immune system into the same location as the tumor cell, allowing our body's immune system to specifically attack it. What are the other efforts we can do to improve our antibodies today? One effort is to try to make better antibodies that recruit more of our body's innate immune system. One of the major advances here and recent FDA approvals was for GA101. This is a second-generation form of Rituxan. It recognizes CD20, but it does a better job of recruiting our body's immune system to the same location. We can also identify antibodies that act like gas pedals on our immune system. So once our immune system is recruited, these antibodies cause these NK cells, part of our innate immune system, to work better. To describe this process a little bit more, here we see Rituxan binding to CD20 on the surface of the lymphoma. Here's our innate immune system, the natural killer cells that have been recruited to that area. Once they become activated, they express activation markers. And then we come in with a second antibody, our gas pedal, if you will. Once we push on the gas, these NK cells work even better, and ideally they kill more tumor. This type of technology is relevant not only for lymphoma, but also for breast cancer, which is treated with Herceptin, and also for head and neck and colon cancers, which are treated with cetuximab. The gas pedal antibody would work for all of these patients. We've identified in mouse models that we can cure mice using the combination of this gas pedal antibody and Rituxan. Well, it's one thing to cure a mouse, but it's more important how patients respond. What I'm showing you here is the first patient that received the combination of CD20 and CD137, the gas pedal. Here you see before the patient started therapy, all of the swollen lymph nodes that were evidence of the systemic lymphoma. This was multiply relapsed refractory disease. After this woman received the combination of these two antibodies, you can see that she developed a complete response. All of those lymph nodes are now back to normal size or entirely gone. She today still remains in a complete response at the end of 2013 when her last scan was done. So gas pedal and brake antibodies are a new technology that is making a dramatic impact in the way that we treat cancer. I've already shown you one, CD137, which we developed at Stanford, and is the one that looks very promising in combination with Rituxan. But there are multiple others. One of the ones that has made a major impact is also known as CTLA4 or ipilimumab. This antibody has actually been able to double the long-term overall survival with patients who have advanced metastatic melanoma, a disease which is very difficult to treat. Other antibodies that are making a major impact on cancer therapy include PD1, a different type of gas pedal antibody. It has been tested in the setting of multiple different diseases, including non-small cell lung cancer, melanoma, lymphoma, as well as multiple others. And what we have seen is that the response rates to the PD1 and PD-L1 therapies are on the order of approximately 30% in patients who have very advanced disease. And the patients who develop a response are able to continue in that response for a long period of time, even after stopping therapy, which is one of the major advances of using immunotherapy. We can combine gas pedal antibodies, and through combinations of gas pedal antibodies, we believe that we can actually get an even better immune response. So here we see a study that combines CTLA4, ipilimumab, and PD1, the last two antibodies that I told you about. What's amazing is showing the response that these patients have achieved. Here you see a patient who has all of these sites of their disease. By 12 weeks, all of those spots are entirely gone. The patients on this study developed a dramatic response. The majority of them had their disease almost completely disappear by the first time that they were imaged with a scan, just 12 weeks after starting the combination of these two antibodies. Again, what's important is there's no chemotherapy. We are using combinations of antibodies in the setting of lymphoma as well. This shows you that same antibody, AntiPD1, used in combination with one that we know well, Rituxan. This study was done at MD Anderson, and what they showed was that there was an overall response rate of 66%, and these were in patients who were previously treated or relapsed follicular lymphoma. Of this, approximately half of the patients obtained a complete response, showing the power of this approach of combination antibody therapy. So there are many different antibodies and many different targets. Some of these targets are present on the tumor, and with better antibodies like CD20, Rituxan, like the next generation CD20, such as GA101, we are able to better target the tumor cell. There are also many different targets on our body's immune cells, and by using gas pedals and brakes, we're able to turn on the immune system even better than it already is to ultimately attack the tumor. With these types of combinations, we believe that someday we will actually have regimens which do not involve any chemotherapy whatsoever, ideally maintaining and preserving patients' quality of life and leading to long-term cures as opposed to short-term remissions. Thank you very much for your attention.
Thank you again so much, Dr. Kohrt, for that very interesting presentation on developments in immunotherapy for leukemia, lymphoma, and other types of cancers. So one of the questions I got was early in the presentation you mentioned cancer stem cells. And the question was, are these stem cells related to the same stem cell research that we hear about to repair organs?
That's a very good question because we use the term stem cells to refer not only to normal stem cells, which are the type of stem cells that are used for regeneration. Ideally, regeneration, say in the setting of spinal cord injury or patients who need partial liver transplant. And these technologies are rapidly developing. That is quite different, however, from cancer stem cells. When we're talking about cancer stem cells, we're talking about the small number of slowly dividing cells that are very difficult to treat with our current therapies. As these cancer stem cells are resistant to our chemotherapy, they're probably one of the major sources of why patients will ultimately relapse. Because of this, we are trying to develop antibodies which specifically target the stem cell, because we believe that if you can target the stem cell, ultimately, when you do treat the patient, that small population which would lead to relapse will now be gone, ultimately, hopefully achieving a better rate of cure.
All right, thank you. And another question we have, someone perhaps with a somewhat of a scientific background that knows this. Not all tumors are the same in terms of the markers that they have on their surfaces. And so the question is, since you mentioned combination approaches, is that one of the reasons why using combinations of drugs might be more effective than using a single drug so that it can target multiple cells within a tumor?
Yes, combination approaches offer the ability to target more than one antigen at a time. And because of the heterogeneity between patients, exactly as you said, this would allow us to treat a larger number of patients and also allow us to treat the multiple different types of cancer cells that are all within the same patient. Sometimes we can use these combination antibody approaches to not only have two antibodies that target the tumor, but to have one antibody which targets the tumor and one antibody which targets the immune response. Ultimately, we want one that actually blocks the tumor initially, and then a second antibody which boosts the immune response.
All right, thanks. Another question that we often get at the Cancer Research Institute, and I'd be very curious to hear how you respond to this. Why do people with healthy immune systems get cancer?
So that's a great question because one of the major challenges that we have is understanding seed versus soil. What comes first? Is it that a patient's immune system becomes less well-primed or less efficient and then cancer develops? Or is that a cancer develops and then it secretes factors that cause our immune system to be less functional? To be honest, we don't necessarily know. What we do know is that patients who are on immunosuppression, so patients that are taking medications which suppress their immune system, they have a higher rate of cancer, which is because of those medications and the effect on suppressing that normal response that should be preventing the development of cancer. What we also know is that patients who appear to have completely healthy immune systems do develop tumors. But once those tumors develop, that immune system is no longer healthy. With these new antibodies, we're able to restore some of that natural immune response. And what has been very impressive is that immunotherapies can treat patients not only with one type of tumor, but many different types of tumors. This shows the power and also the ability to apply this to a large number of patients and hopefully benefit patients not only with leukemia, but lymphoma and other solid tumors as well.
Another question, what is the ideal stage for treatment with immunotherapy? At what point should a patient that's being treated with chemo or radiation consider being treated with an immunotherapy?
Given what we know today, I don't believe that we are restricted to any one patient population. With our new therapies such as PD1, PD-L1, even with Rituxan, what we know is that patients who are stage 1 respond, and we have patients who have stage 4 disease or advanced disease respond as well. Ideally, the patient's immune system would want to be as effective in either of these settings, and that's our goal, is that we develop therapies that are not limited to patients who either have a small or a large amount of disease. If we were to pick one which would be the most promising, we believe that likely less disease equals a better immune system or more immune competency and a better response. But we have not been able to show that actually. Patients with advanced disease appear to be responding in some cases just as well as patients who have very little disease.
So in a similar vein, is age at all a factor? Or is someone who has HIV or some other immunocompromised state of health, are those factors in whether or not a person would be likely to benefit from an immunotherapy?
So what we have seen thus far is that patients who are older seem to tolerate immunotherapy well, much better than they would tolerate cytotoxic chemotherapy. So immunotherapy probably has a major role in patients who have a poor performance status or older age. And it appears that their immune system, even though it's not the same as a younger immune system, is still able to respond and to benefit from these therapies. In the setting of HIV, this is less well known because unfortunately many clinical trials do not include patients who have HIV. With that said, there is a major effort currently ongoing at our National Cancer Institute to study these immunotherapies in the setting of infectious diseases like HIV or hepatitis C, for instance. And hopefully in a few years, or maybe less, we'll have the answer to whether patients with HIV respond just as well as patients who do not have an infectious disease.
Thanks for that. Just a couple more questions. Are there any risks involved with treatment of immunotherapy? People are very familiar with the negative side effects of treatment with chemotherapy and radiation. What are the potential side effects of treatment with immunotherapy?
So the effects of chemotherapy and radiation, the nausea, the vomiting, the hair loss, are all affecting cells that are rapidly dividing. And unfortunately, there are many normal healthy cells that are rapidly dividing in our body. With immunotherapy, what we are doing is boosting the immune system. And so what you could imagine is that if the immune system is too active, if it is overly active, you could induce autoimmune disease. Sometimes we do see that patients develop colitis because of the T cells that will infiltrate the areas of their colon, or hepatitis, which is a result of their T cells infiltrating the liver. The same thing is true in the lungs with pneumonitis. However, what we are able to do, because this is a predicted side effect, is to lower the dose or to give a small dose of steroids to ensure that these autoimmune side effects from a boosted immune system don't compromise the ability of the patient to be treated and to benefit from the underlying therapy.
Okay, just a couple more questions, and then we'll wrap up this excellent presentation. You mentioned gas pedal type antibodies, and one of them is now available on the market. How soon will we have more of these, and when will they become available to patients? I don't know if you can answer that, but I wondered if you had any thoughts on kind of the drug development process of immunotherapies.
So we know that CTLA4, as you said, is the best example of an immunotherapy that's been successful and that has actually been brought to the market. It has had a major impact in the setting of melanoma and is being tested in multiple different tumor types now. There are also the antibodies to PD1 and PD-L1, and those clinical trials, the phase 3 clinical trials, are ongoing right now. So I anticipate that at the end of this year or sometime in 2015, we will see the approval of the PD1 and PD-L1 antibodies. Now, there are additional antibodies that are in development, and they're much earlier in their clinical development. And so it's difficult to predict exactly when they will come to the market. But one can speculate. From the time that an antibody starts in its phase 1 testing to the time that it's approved is often on the order between 2 and 5 years. And so once these antibodies do come to the clinic, then we can have a better timeline for when we anticipate their approval.
Okay. And then I guess the last question for today, will immunotherapy ever make chemotherapy and radiation obsolete? So in your presentation, you showed how immunotherapy is currently being combined with chemotherapy or radiation. But you did hint that perhaps in the ideal future, we would not need to rely on the conventional treatments of today. How realistic do you think that is, and what is the kind of time frame that's involved there?
I believe that it is the ultimate goal for essentially anything less. The reason is that patients' quality of life is critically important. We need to convert cancer from a disease that people die of to a disease that people live with. And live with in a sense do everything they normally desire. Because of that, I do think that cytotoxic chemotherapy is essentially going to be a thing of the past. With a targeted therapy, such as a combination of Rituxan and an antibody, patients can have a normal quality of life, and as we saw in that one patient, they can develop a complete response and maintain that response. The advantage of immunotherapy is that once you get a response, your body's immune system is more educated. It's smarter. It knows what the tumor looks like. And so the next time that tumor tries to grow, when a patient would normally relapse, because they received immunotherapy previously, their body's immune system can actually attack it proactively and prevent that relapse. So I do believe that someday we will have therapies which combine various forms of targeted therapy and immunotherapy. So these two types, not only chemotherapy, but potentially radiation as well. There may always be some role for chemotherapy, radiation, and surgery. However, ultimately, I do hope that immunotherapy replaces them, again because I believe that quality of life is critical for our patients.
Forgot to turn on my microphone. Sorry about that. My question was, do you think that we will ever develop vaccines that prevent cancer from forming in the first place? And I know that many people are familiar with Gardasil, which is a vaccine that inoculates against a virus which is known to cause certain types of cancer. But many cancers are not linked to viruses. So what's the likelihood that we will develop ways to prevent ourselves from developing cancer in the first place by using technology based on the immune system?
Cancer vaccines as a proactive form or a prophylactic form require us to know what's causing the tumor to develop, such as a virus. In the cases of viruses like HPV or EBV, I believe we will have vaccines that prevent, just like Gardasil, but ultimately also vaccines that treat. So patients that develop a cancer, they receive a vaccine as a therapeutic. In order to actually have cancer vaccines as a prophylactic for other tumor types, we need to identify the antigens and the drivers of those types of cancers. That technology is in development, it is not there today. But ultimately, maybe 10 years from now, we will see that there are more than just Gardasil on the market, and that there are patients who are able to prevent not only HPV, but many other types of associated cancers.
Okay. Sorry, we got one last question about cytokine storms, that's kind of jargon talk, but basically it's, well, you can explain in basic terms what a cytokine storm is and how that's a potential risk of treatment with immunotherapy. But the question is, are there any markers that would help us predict which patients might be likely to experience these, and what strategies could we develop to circumvent creating such a bad effect in a patient being treated with immunotherapy?
Sure. Cytokine storm, the best example of this phenomenon is when we give a high-dose IL-2, which is a cytokine that stimulates our body's natural killer cells, our NK cells. These are part of the innate immune system. Those NK cells release more cytokines, and this results in a cytokine storm, which basically looks like a very severe flu. Fevers, chills. They also have problems where they have a low blood pressure. All of these things are very dangerous. So we need to identify ways where we prevent that cytokine storm from happening. We've developed one way in which we are able to stimulate the body's NK cells, but specifically just the NK cells that are in the environment of the tumor and a monoclonal antibody like Rituxan. So when we use CD137, that gas pedal antibody, patients don't get cytokine storm because the only NK cells that they target are those NK cells that are already infiltrating the tumor. By localizing our immunotherapy to specific sites of disease and not specific sites of normal tissue or the normal immune system, we're able to prevent things like these adverse events such as cytokine storm. This is the type of technology which is very important to develop because it ensures that patients who receive immunotherapy continue to have very few side effects from their treatment.
All right, well, thank you. That's all the time we have today for questions. I'd like to thank all the participants who are viewing this. I'm sure we'll get some follow-up responses from people, and we'll try to address those in our blog or on our Twitter feed, which you can find at twitter.com/cancerresearch. I'd like now to just let you know about our next webinar coming next month. Dr. Larry Fong from the University of California in San Francisco will be addressing how the immune system is being used to target and destroy colorectal cancer. So please, if you haven't registered for that, you can do so at cancerresearch.org/webinars. Also like to remind you that June is Cancer Immunotherapy Month, and during the month of June we will be hosting a number of educational webinars, 4 in total this year during the month of June, as well as a number of other very exciting education and awareness raising activities. So if you would like to learn more about this, you can sign up for our newsletter on our website at cancerresearch.org, and we'll be sure to update you, or as you can follow us on Twitter or Facebook, which is a good way. Here are those links to our Facebook, Twitter, and our blog. Our blog is updated pretty regularly with lots of exciting content with patient success stories, latest activities in cancer immunotherapy research. So be sure to check that out to stay current. So thank you all very much. We're about to conclude the webinar. After we shut this down, you'll be directed to a very brief survey. Just a few questions. It would be very helpful to us if you could please respond and provide your feedback to us so that we can ensure we're providing the best service to you. Thank you all again. This is Brian Brewer from Cancer Research Institute. Have a wonderful day.